Kevin Anbari, stellar surgeon, trained at the Harvard, University of Pennsylvania, Charlie Ang's fellowship, and actually has an MBA from Wharton. So with the economic crisis going on, there's a lot of healthcare economic issues, and we could defer to Kevin. First question of a metal-on-metal hip in somebody that has no symptoms, Kevin.
I would say that the attention has been paid so much to this recently because of a recall of a particular implant. And the good news is that implant was put into a small number of people to begin with, and the other large majority of people who have metal-on-metal implants are actually doing just fine, just like you are. However, I could understand from a patient standpoint hearing about all this and being somewhat concerned. The best thing, I think, is to talk to your surgeon. Hopefully your surgeon is somebody who does a lot of hip replacements and has kept up on the more modern ways of diagnosing this problem. There are certain things that we have learned over the last few years. Some of it is measuring the metal ions, but that itself doesn't really tell us that much. Some of it is imaging the hip in certain ways to see if there's any damage to the muscles, like you said. You actually said it very well. How you described it was actually a very good description of how we would describe it. Certain things about an MRI, for example, can tell you if there's fluid collection in the hip that may indicate a metal-on-metal reaction. And in certain cases, if you're having trouble, the surgeon may say, look, let's take the metal liner out and put a plastic liner just to put your mind at ease. But some may say, if you're doing fine, we'll just follow this every 12 months, see how you're doing, look at your x-rays, look at your blood levels, and just follow you along. There are tens of thousands of people with very well-functioning metal-on-metal hips who I would recommend not to have anything done because they're doing just fine. And to expose them to another surgery when they're doing well doesn't make a lot of sense. So I would just have a discussion with your surgeon about it, and if that makes you feel comfortable, then that's what I would do.
Kevin, is it all these companies that have the same issues, or is it more one company where we're focused on?
I think the issue with metal-on-metal in general is some of it is implant specific because some implants seem to have done a lot better than others, and some of it is actually specific to how you position the implants. We've learned a lot more about how certain ways that you position the cup, for example, lead to more wear on a particular part of the metal-on-metal articulation. So I think the concept itself is a valuable concept. The reason we came up with metal-on-metal in the first place is because back in the day, plastic, which was the Charnley surface, used to wear out a little bit too quickly. So when we started to do them in younger patients, the idea is, well, we can take the metal out of the equation altogether and put a metal-on-metal surface. So there was a lot of common sense behind it, and I think that still is a reasonable thought. However, we've learned a lot more. Now that we put them in so many people, we learned a lot more about certain things that make them more likely to wear out more quickly and give people problems, and certain ways to make them less likely to give people problems. So some of it is implant specific, and some of it is actually just some lessons that we learned about positioning of components. One thing I do want to add in general about the whole articulating surface of the hip is that because of some of these issues, the vast majority of hips being done in this country right now are a metal ball on a plastic socket, which is sort of the original and best. It's the cornflakes, and the reason is surgeons don't want their patients to even have a small chance of having any of these problems. So despite a lot of the attention being paid to this in the media, this is more of a problem in the past than for the future, because I think most of us now don't want to have that controversy be even a part of our patients' lives at all. So I would not lose sleep over that going forward, is basically what I would say about that.
We tend to talk about the complications of the hip surgery, but again, as we started the first show, this is one of the most successful procedures in all of surgery. So you got to put that in perspective. Kevin?
Yeah, basically I was just concerned about some of the impressions that were being given by some of the questions from the first show. Bottom line is hip surgery, hip replacement surgery specifically, is still probably one of the best surgeries in all of medicine. And now that we know what we know about it, we are even better able to make sure that the hip that we're putting in is something that's going to last a test of time. Most hips, the vast majority of them now are titanium pieces, which are very benign, with a metal ball and a plastic socket, which is as uncontroversial as it gets. So I want to just give the correct impression here that the thousands and thousands of people who are getting the surgery on a yearly basis are doing just fine. And I don't want some of the complications that we've encountered in the last few years to cast a shadow on that. That's all.
We're talking about anterior approach, the controversy. Is it for every patient? Is it for every surgeon? Kevin Anbari, you've also embraced this anterior approach. What's your thought on this procedure? Does it make you faster? Does it make you better? Is it for every patient? Is it for every surgeon?
I actually have liked it quite a bit. The main benefit is for the patient. The surgeon is irrelevant, really, from the patient standpoint. It does take a bit of a learning curve, and I did dedicate many hours to training, traveling to different courses, like Leo said, and observing live surgery, scrubbing in on surgery to feel comfortable doing it. I think the procedure actually is kind of a cool procedure. It's nice to have the X-ray there. You have a lot more confidence about the leg length, exactly like Leo said, and the fact that the hip is going to be there and not going to pop out of socket, which is also very nice. I don't think it's for everybody, based on a variety of different things. Some anatomic problems in the bones that pre-exist, or hardware that exists from before. Some people who are very large, the belly may get in the way of actually inserting the piece that goes into the thigh bone. But several surgeons have actually embraced that procedure as their go-to procedure for hip replacement. So when you said before about, oh, there are multiple criteria, well, sure, but overall, you can actually do quite a few people from that approach. So it's not for every patient, but it's probably for a lot of patients potentially. But primarily, the surgeon who does it has to be comfortable doing it and has to feel comfortable that they're doing the right thing for the patient. So that depends on a conversation you have with your surgeon. They do say in orthopedics not to be the first or the last, or actually probably in all of surgery, not to be the first or the last to try any procedure. So I agree with the sentiment. With the anterior hip approach, it's not something that was just created yesterday, though. This has been something that was studied at length for years, and I think even with the new push in the last few years, it's not something that just came out in the last month or year. I've actually watched it and waited to see if it was going to balloon or whether it was going to go by the wayside, and it looks more the former than the latter.
Do we have to replace the whole joint? Can we just resurface the worn out articular surface? Anybody on the panel do hip resurfacing? Kevin, you got it.
I think basically the point of resurfacing is that instead of cutting off the ball of the hip or the top of the thigh bone, you're just basically taking the surface off and putting a new surface on it. It certainly makes sense from a common sense standpoint. You're saving bone. I think if you go on the websites, you see a lot of claims to that procedure that aren't justified. You see people climbing rocks, and it makes it sound like it's such a different procedure than hip replacement. Truthfully, a younger active male patient can probably do the same activities with a hip replacement as they can with their resurfacing. The one thing you're definitely doing differently is that you're saving bone. You're not putting the thigh bone component inside the thigh bone, you're just putting a surface on the top. So that's really the true advantage. At the same time, it's by definition a metal on metal hip. And if you heard a lot of the questions about metal on metal surfaces and some of the issues with it, that's, I think, why it's become less popular over the last 1 or 2 years, because we're a little bit more apprehensive about the whole metal on metal issue. For some people, though, I think it still makes sense if they are a young active male. When it comes to indications and contraindications, I think that one you really have to have a good conversation to see if it makes sense for you or not. I've had people who are, a 7-year-old female who comes in and asks for a resurfacing. That wouldn't make sense for that person at all. Really makes sense in a certain subset of population, and they have to be fully aware of the whole metal on metal issue and whether they're comfortable with that. And some people really are, because they don't want plastic in their hip for whatever reason, and they like the idea of just putting the surface on instead of putting the piece down in the thigh bone. I actually saw a show on TV recently. It was a documentary about foreign tourism, medical tourism, and this guy who didn't have insurance went to India to have a medical resurfacing done. a hip resurfacing done. So I thought it was kind of interesting, but I think it makes sense in a certain subset as long as you're aware of those issues I said. Good questions. Ceramic is not really an option with the current modern hip resurfacings. I will say, though, that the one that is most typically used is one that was very well researched, and I would have no problem implanting it in my patients, and I have in the past, despite all that we've learned about metal on metal. I don't hardly ever do any metal on metal hip replacements anymore, but if somebody wanted a hip resurfacing, like I said, it would be a metal on metal hip, and I would feel very comfortable with that. And it makes sense in the younger active male population. And that's been studied in excruciating detail by the originator of this from Europe. And actually, it's been shown to be a really good prosthesis. In terms of a ceramic in a hip replacement, like it's been said before, everything in life has an advantage and disadvantage. The point of ceramic is that in the laboratory, when you put a ceramic ball on a plastic socket and you test it with millions of cycles, it seems to wear the plastic out even less than a metal ball does. But the main advantage really right now to hip replacements in the last 10 years is that the plastic itself is much better quality, like Dr. Sharkey said in the last show. Ceramic may be, however, even better than a metal ball in reducing that wear rate even more. The main disadvantage is a 1 in 10 to 20,000 chance of the ceramic ball breaking. But what I tell my patients is bone can break, metal can break, and so can ceramic. But it's extremely unlikely. You can take a ceramic ball and literally throw it across on the wall and it won't break. But that's something that I do tell my patients for the sake of completeness. It does make sense in the younger patient. Does that answer most of the points?
It does. Has anyone ever heard of a squeaking hip?
Right, so that, well, the squeaking is a particular design from a particular implant company that is a ceramic ball on a ceramic socket. What I was talking about is a ceramic ball on a plastic socket. And there actually there is a point to putting a ceramic ball on a ceramic socket because then the wear rate is basically zero. But you do have that occasional issue with squeaking, and I've witnessed it in some patients who have come for second opinions, and it's actually very intriguing. It demonstrates what the body can do with some of the things that we do to it, you know.
How often do we have to fine tune the hip? And I'll bracket that question and say, what is the reoperation rate in the first year after a primary hip replacement in a healthy person? I
think unlike LASIK, when you're trying to get to 20/20 vision and maybe you get to 20/40 and you're not there yet, this is not the same thing. I mean, you're taking out the arthritic joint and putting in a new joint that should be good right away. The reasons to reoperate can often be, actually it's not often, it's very rare, but the reasons to operate could include things like infection of the skin incision, say if the hip dislocates or breaks, especially people maybe with weaker bone. But overall, I would say the rate is very low.
On a difficult problem, on a second revision, on a young, active, athletic male, possibly with some bone loss, what are the options for bone loss? Dr. Anbari.
The good news is that we have come up with new technologies to combat that problem. I mean, a second time revision, there's probably going to be some significant degree of bone loss potentially. The best advice is to make sure that you're with a surgeon who deals with that problem on a regular basis. And in the past, we used to rely on what you call allograft, which is basically bone from the tissue bank. But now there are actually very good technologies where we are different augments made of a specific type of metal that has similar properties to bone that can actually be used, and then you take what it could be a large defect and you make it a much more manageable defect. So that's probably one of the good things that have happened to hip revision surgery in the last few years.
Does that answer your question?
Well, the new material that I was referring to is actually just a piece of metal made of tantalum. But bone graft has been used for a long time with good results. It's questionable whether it really, whether there's more life in that bone or not. It basically just used initially as just a structural strut, so you can implant your new cup. But we've used for people, for example, with tumors and things like that. We've used large pieces of bone from cadavers to substitute for that, and it seems to work just fine.